Okay, hi everyone. Good morning. It's a bright Sunday morning, and welcome to the Asia Pacific Intensive Care Symposium. I can all imagine in the real world, we'll all be scurrying from the big plenary room where DMS has just given his talk, and we're all so confident about our response for COVID-19 in Singapore, to this room where we now look at how all of us, it's not just intensivists, but all of us need to know how to deal with hospital-acquired infections. Even in the lay press, there's so much talk about hospital-acquired infections. And as specialists in the hospital and as care workers in hospital, I think we all need to know a bit more about this very, very important topic, a topic that really affects outcomes in all of us and our patients. Okay, so to kick off, we have Dr. Lee Tao Hong. Tao Hong I've had the pleasure of working with Tao Hong over the years. We've set up various services in Diagnosing, and Tao Hong very proudly runs the Antibiotic Stewardship Program now in Diagnosing Hospital, and is very involved in COVID care recently in the NCID ICU as well. So he's going to talk to us about COVID-19 and concomitant bacterial lung infections. Thank you, Tao Hong. And just for everyone's sake, can you please send us the questions through the Q&A? We will try to tackle them together as a group at the end of the session. Thank you very much, and the floor is yours, Tao Hong.
Thank you, Jonathan. Thank you for the kind introduction. Just let me share my screen here. Okay. You can see my screen currently. Okay, good. Okay, so I'm going to spend the next 20 minutes or so talking about COVID-19 and concomitant respiratory bacterial infections, and just a bit on viral infections as well. So let's get started. No financial disclosures to declare. Now, this is the scope of my talk. So I'm going to spend the first few slides talking about some introduction on COVID-19. Then we'll talk about various aspects of co-infections, bacterial infections, respiratory viral infections, and secondary bacterial lung infection or hospital-acquired infection, bacterial co-infection in the critically ill, as well as some slides on biomarkers in COVID-19, where it will help us make the decision on starting antibiotics. Now, bacterial co-infections are relatively common in severe influenza. So as you can see from this study of patients with influenza and admitted to ICU, bacterial co-infection is present in about 22.5% of the subjects. And in the pediatric population, it's slightly lower at 17.5%. Although the proportion of patients with severe influenza in ICU, there were about 23% who had bacterial infection. You can see that the vast majority, 94%, did receive antibiotics. So you can see that there is a much higher proportion of patients who receive antibiotics, even though it may not have been necessary. And because it's difficult to rule out bacterial co-infection or bacterial superinfection or secondary infection, it's difficult to differentiate these two entities. WHO and the Surviving Sepsis Campaign guidelines have recommended giving empirical antibiotics in patients with severe COVID-19 or patients who are mechanically ventilated. And really, this recommendation is extrapolated from the influenza data, but in the guidelines, they also recommended giving just a short course of antibiotics and assess for de-escalation daily. There is high rates of antimicrobial prescribing reported in the COVID-19 literature, and in a review of the literature in about 2,000 patients, close to 3/4 of hospitalized patients receive antibacterial therapy. So really the question to ask is prescribing antibiotics in COVID-19 justified? and really how common is bacterial co-infection in COVID-19. So I'll just go through a clinical case. Okay, we'll also go through the journey of this patient as his COVID-19 infection evolves. So we have a 56-year-old male who has a past history of hypertension. He presented with a cough, a dry cough for a week. He had fever for 4 days, and he denied being breathless. He was actually quite well clinically. Blood pressure is normal. He's not tachypnic. He's saturating 99% on room air, and he was really quite comfortable. On examination, there were bilateral fine crackles in the lower zone. The white cell is 4.2, the C-reactive protein is 20, LDH is about 400, and the chest X-ray is shown on the right. There were mild bilateral lower zone airspace changes, and his SARS-CoV-2 PCR was detected. So then will you start antimicrobials? Okay, so remember this is a man who, well, has, by all intents and purposes, a community-acquired pneumonia, and he is positive for COVID-19. So will you have started something really narrow spectrum, amoxicillin, cephalosporin, a macrolide, a combination, and then with or without oseltamivir or influenza, or would you not have started any antimicrobials at all? So the next few slides are going to talk about co-infection in patients who have newly presented with COVID-19, as for this patient. So the prevalence of a bacterial co-infection, okay, it is studied in this paper, I believe it's from Spain. There were 2,226 hospitalized patients with a median age of 61, so quite similar to our patient here. But 80% had at least one comorbidity, and death occurred in about 20% of the patients. So you can see that the death rate is quite high in this cohort. And bacterial pneumonia was actually identified in just 2.9% of the patients. But of course, for those patients who died, there's a higher chance of them having a bacterial pneumonia. So close to 10% of those who died had a bacterial pneumonia. But you can see here that for most patients, the incidence of bacterial pneumonia is actually quite low, just about 3%. In another study, this is done in the UK, again, hospitalized patients, there are 836 in this cohort. And you can see that the median age in this group of patients is 69, okay, so quite high. And these are the investigations that were done, the number of investigations and the percentage of patients who had these investigations done. About 77% had blood cultures, and the rest of the microbiological investigations are as such. And you can see that at 3.2% had a confirmed bacteria isolated in the patients who were admitted within 5 days. Again, so about similar to the previous study, about 3%. And this is the further breakdown of what organisms this patient had. Okay, so 2 patients, okay, had blood culture that were positive. Okay, so this is community acquired, and this is healthcare acquired. 4 cases had a community acquired Staph aureus from the respiratory culture. 3 cases had Pseudomonas from respiratory culture, and in total, 5 cases over here had Enterobacterialis, gram-negative. Interestingly, none of them had a positive pneumococcal antigen, Legionella antigen, or flu influenza positive. Among patients with bacterial co-infection, in another study, this is a meta-analysis. 30 studies were included, and there were about 3,800 patients. About 7% had a bacterial co-infection. But among patients who were in the ICU, it is about 14%. And you can see on the chart that the most common bacteria is Mycoplasma, followed by Pseudomonas and Haemophilus influenza. Now, in the same study, the authors also looked at viral co-infection or influenza co-infection. So the prevalence of viral co-infection is lower, it's about 3%. And you can see from here that the most common is actually RSV, respiratory syncytial virus, followed by influenza and rhino and enteroviruses. So influenza A was identified in 15.5% of the 3% who had viral co-infection. So back to the clinical case. So initially the patient was not started on any antibiotics. 2 days later, at day 9 of illness, he still had a low-grade fever. His oxygen saturation is 90% on room air, and he was given 2 liters of oxygen intranasally. He was mildly tachypnic. He still appeared non-toxic, but this time around, his white cell has increased to 12.8, and the CRP was 335. So would you give antibiotics now? So here we have a patient who still is persistently febrile. He still has a dry cough. He desaturated while on room air, and he has elevated white cell count as well as the CRP. So this is where I think most patients or most physicians have a problem. Is this clinical picture due to a secondary bacterial infection? Or is this the development of ARDS, which is seen in patients with severe COVID-19 infection? So let's look at secondary bacterial infection. What is the prevalence? In this multi-center study of about 470 patients, the median age is 53. And you can see right here that 3/4 of this cohort has got a 0 for CUP65 score, so really a mild pneumonia. A quarter has a CUP score of 1 to 2, and just 1% had a CUP65 score of 3 to 4. And you can see here that the prevalence of a secondary bacterial infection is about 8.5%. On the other hand, could this also be ARDS in COVID-19? And you can see from this early paper from in JAMA, ARDS developed at a median of 8 days from symptom onset for COVID-19. Okay, so this fits quite well with our patient's clinical progression. Okay, this is day 9 for him where he had experienced desaturation. So the patient was started on intravenous co-amoxiclav with oral doxycycline for empirical community-acquired pneumonia treatment. And he was transferred to high dependency unit for close monitoring. This patient presented in February where in Singapore, the case numbers were quite low at that time. And because clinical characterization wasn't so clear, we erred on the side of caution and we transferred all patients who require supplemental oxygen to the high dependency unit. This patient was not on remdesivir or dexamethasone because this patient presented in February, and these are not proven therapy. And antibiotic was switched then to IV piperacillin tazobactam with vancomycin while he was in the high dependency unit. This is to cover for hospital-acquired pneumonia. Two days later, day 9 of admission and day 11 of illness, the patient continued to have a fever. The white cell now is 8.9 with a CRP of 259. You can see that the chest X-ray on the right side, it has progressed further. He had low blood pressure. He was started on an inotrope. Because the PF ratio was poor, he was intubated, and the antibiotic was switched to IV meropenem. Then we look at co-infection in patients who are critically ill. So what's the prevalence of a secondary bacterial infections in one who is critically ill? So you can see here 476 patients, and 67% of the patients receive antibiotic. About a quarter receive corticosteroids. Secondary bacterial infection in the whole cohort is 8.5. But you can see from here that patients who have a more severe illness would have a higher proportion of them having a bacterial infection. So in the critically ill, in this paper, it's about a third of the patients having bacterial co-infection. And you can see that the amount of antibiotic use goes up with disease severity, which is not surprising. And in this meta-analysis, the prevalence of secondary bacterial infection in the critically ill is about 16%. Now, this patient at day 14 of illness, at day 4 of intubation, he improved. The inotropes got weaned off, and this is the endotracheal aspirate culture. So as no organism was seen on the gram stain, the culture was rejected. Because he clinically improved and there was no positive culture, meropenem was stopped. 2 days later, however, he vomited, he desaturated, and he spiked another fever. His CRP went up again. White cell also went up again. And he was started on piperacillin tazobactam. Now, this happens to be his endotracheal tube aspirate culture. So he had a very sensitive Klebsiella pneumoniae. The antibiotics were switched from piperacillin tazobactam to coamoxiclav. He improved quite quickly and was extubated 2 days later and then subsequently discharged from the hospital. I suppose this man, despite being sick, he was lucky in the sense that his Klebsiella pneumoniae is a very sensitive one. But for some other patients, the endotracheal aspirate could easily have been this, right? Stenotrophomonas, or it could have been a multi-drug resistance Pseudomonas or A. baumannii, or carbapenem resistant Enterobacterialis. So in summary, okay, in terms of different patient subgroup, the risk or the incidence of bacterial infection in COVID-19. In terms of co-infection, meaning patients first presented with COVID-19 and at the same time whether they have a bacterial infection. Okay, in this meta-analysis, it's about 5%. Okay, bacterial infection happening in about 5% of patients who presented to the hospital with COVID-19. Amongst patients who have COVID-19 and subsequently worsen and develop a secondary bacterial infection, it's about 16%. And likewise for patients who are critically ill. Now I'm just going to spend the next few slides on biomarkers, okay, because I think as I shared in the earlier slide, it is sometimes difficult to tell whether a patient has worsened, has high inflammatory markers. Is it because of the hyperinflammatory phase of COVID-19, or did the patient really develop a secondary bacterial infection? So I'm just going to focus on procalcitonin and CRP. So in this study, the authors found that a higher procalcitonin level was associated with severe COVID-19. Okay, so if the procalcitonin level is elevated, then there is a nearly 5-fold higher risk, okay, of a severe SARS-CoV-2 infection. But what the authors didn't mention here, or is not studied, is whether this is due to bacterial superinfection. In a separate study looking at procalcitonin levels, the authors found that out of 95 patients, as the patient's illness severity increases, okay, from moderate to severe to critical, the procalcitonin level also increases. Patients who are treated successfully and discharged, their procalcitonin levels come down. Okay, and for patients who died, most of them had a improvement in procalcitonin level before going up again. Again, this paper did not study whether these patients have bacterial co-infection. They just drew a parallel between severe COVID-19 and a higher procalcitonin level. So you can see here that the procalcitonin levels in the moderate group, the severe group, and the critical group are shows an increasing trend. But to me, at least as a clinician, these really small numbers may not really differentiate patients very well. So in another study that is published in Critical Care, the authors were musing, thinking of biomarkers for antimicrobial stewardship. So the authors recognized that antibiotics are frequently used for patients with severe COVID-19. So in their patients, 66 patients, all in the ICU, half of them developed bacterial infections and the other half did not. And these charts show patients who did not develop bacterial infections. And you can see that from the procalcitonin on the left, the procalcitonin levels gradually drop as the days goes by. Okay. For CRP, the change is, the slope is steeper. So patients who with COVID-19 who were admitted to the ICU, they had a rather high level of CRP. And you can see that the procalcitonin levels were were lower than the CRP levels when you are comparing them to the usual cutoff. So for procalcitonin, usual cutoff is about 0.5. Okay, and so these patients are, just barely above that cutoff. Whereas for CRP, most of us use a level of about 100 to signify that there's something sinister going on. And so this is much higher than that cutoff. So it seems that CRP is a better marker for COVID-19 disease severity. Now, in terms of patients who develop secondary infection, so let's focus on the procalcitonin chart. In blue are the patients who develop a secondary infection. In yellow are patients who did not develop a secondary infection. Day 0 is the day where the patients develop secondary infection. And you could see that on the day that the patients developed secondary infection, there was a jump in the procalcitonin. In patients who did not develop secondary infection, the procalcitonin level stayed relatively stable. Contrast with the chart on the right side, talking about CRP levels, you could see that patients with a secondary infection, okay, the CRP level was high. It went up just a bit more at the start of the secondary infection, and then with treatment, it came down as well. Whereas for patients with no secondary infection, the CRP trended down quite nicely. But you can see from this chart, it appears that procalcitonin level, okay, is a better signal to suggest a secondary infection. Okay, you can see that it's quite stable right here, and then it jumped up. Whereas CRP was always high right in the beginning, even before the secondary infection set in. In the same study, then a receiver operating curve were drawn to illustrate the sensitivity and specificity of procalcitonin and CRP. So the ROC analysis of procalcitonin is 0.8, whereas that of a CRP is 0.76. And if you look at the specific levels of procalcitonin, if the patient had a procalcitonin level of 0.25 or less, then the negative predictive value is 81%, which is reasonable. Okay, so if a patient has got a procalcitonin of 0.25 or less, then you have a 81% chance that the patient does not have a secondary bacterial infection. And if you take a procalcitonin level of 1 or more, then the positive predictive value is 93%. Intermediate levels of procalcitonin were not very useful. Okay, so it's always in this gray area where it could go one way or another. Contrast this with CRP, the predictive values, okay, the negative predictive values and the positive predictive value were less robust. So in summary, bacterial co-infections in patients with COVID-19 at first presentation is uncommon. A couple of studies show that it's about 3%. Viral co-infections also occur in about 3%, of which RSV and influenza are the most common. Presence of bacterial co-infection increases with COVID-19 severity and are highest in those critically ill. ARDS, inflammatory response in patients with severe COVID-19 can mimic a secondary bacterial infection, but most patients actually do not have a bacterial infection. And antibiotics are likely overprescribed in most cases. Procalcitonin level may help in decision-making to start or withhold empiric antibiotics. That's all I have. Thank you.
Thank you very much, Tao Hong. Actually, I just have two quick questions pertaining to your case. Firstly, in the patient that you presented, was the procalcitonin done, and what was it? How did it correlate to help your management?
Right, I did not give the procalcitonin levels in my talk. Is because they were in the gray area, so it didn't really help us one way or another. And the physicians were starting and stopping antibiotics based on the patient's clinical picture.
Well, I think that mimics the real world, and it really highlights the fact that you really do need a team to at least make decisions on the ground, and we will not be replaced by robots at this time yet. Yeah,
thankfully so. Yeah.
Just remind all the audience, can you just tell us quickly, for procalcitonin, traditionally, what kind of infections give a raised procalcitonins and what kind of infection does not?
Right, so traditionally it's the bacterial infections and parasitic infections and some fungal infections can raise procalcitonin, whereas viral infections usually do not. So you would expect that then COVID-19 being caused by a virus will not significantly raise procalcitonin levels, but there's always exceptions. Even patients without infection, they may have SIRS from other causes such as burns or acute pancreatitis or even intracranial injury can cause procalcitonin level to go up. So we always do have to take the level and correlate clinically and see what the patient's clinical situation is.
Yes, thank you very much. And let's remind the audience that you can post your questions on the Q&A and we'll take more questions at the end. Thank you very much, Dr. Lee.
Thank you.
So next up, we're going to talk about a different type of infections, one that really, stuns me most of the time, which is fungal infections. So we're going to talk about fungal infections in the ICU, and to take us through this very tough topic, we have Dr. Jasmine Chung. Jasmine is a consultant, infectious disease consultant at Singapore General Hospital. She runs the antibiotic stewardship program there, as well as the transplant or infectious disease transplant service as well. So two very tough areas. Thank you, Jasmine, for taking us through this topic.
So I'd like to thank the organizers, and Dr. Tan, thank you for the kind introduction. Just give me a few seconds, I'll share my screen. Hang on. Okay, the topic for today is fungal infections for the intensivists. And to be honest, this is what I feel most days. You have a sick patient in front of you. The fungal infection is often difficult to diagnose. Not only that, they are critically ill patients with multiple comorbidities. The fungal infections are difficult to treat. The drug options may be limited, and we have to weigh in efficacy versus toxicity considerations. Outcomes are often poor, and of course, this is associated with increased healthcare costs. Then what do we do next? So in addition to all the points that I've raised, we also know that there's a change in the epidemiology of fungal infections in the ICU over the years. potential factors which is driving this is that there are change in host factors, there are new susceptible groups, the advances in medicine, chemotherapy and immunotherapy options have expanded. ICU care has also taken a different phase. You have more elderly patients coming into ICU. Surgical techniques have improved, supportive care or organ support systems have also advanced, and there's also improvement in sepsis management. And therefore, it's not surprising that we are dealing with more fungal infection these days. To compound matters, there's emergence of novel or rare pathogens. And also, there are also drug-resistant fungus pathogens, which are also increasingly being isolated. So what do we do next? So the focus of my talk today, I thought I'll do it differently. There are some themes to be addressed. I always thought that it would be good to go back to the mycology. If we know mycology 101, and perhaps we would be able to maneuver this complicated field a little bit better. We'll also look at the epidemiology of common fungal infections in the ICU with a focus on patient evaluation and management, and some quick words on emerging fungal infections in the ICU. So this is Mycology 101. If we break it up simply, there's the fungus there. There are a few categories of fungus, the yeast, the mold, and the dimorphic funguses. And the yeast, the Candida infections are the ones that we commonly encounter. They are found on the skin and on the intestinal tract. Next up would be the molds. And of the molds encountered in the ICU, what we would probably encounter most would be the Aspergillus infection. Aspergillus and other molds, hyaline molds, are found in the environment. It's in the vegetation, it's in the air. There's a predilection for damp places. So we need to know where these funguses come from before we can address the suspected fungal infections in the ICU. And last but not least, the most feared would be the aseptated hyphae, which is the zygomycetes or the mucormycosis that we see, and often the outcomes are poor in this group of patients. So there are many different types of funguses we went through, and there are also different drug categories, the amphotericin category, the echinocandin category, as well as the triazole category. And this is the list of the FDA approved indications for the different funguses. Most of the antifungal agents, you can use all the different drug categories to treat the candidiasis. For the mold infections, the spectrum of activity is slightly different. So this is FDA approved indication, but it doesn't equate with activity against the funguses. And this table here represents activity of the different antifungal agents against the different funguses that we see. I want to highlight a few things for the difficult to treat mold infections. Amphotericin has a broader spectrum of activity, and posaconazole and isavuconazole are also quite broad in their activity. Now, when we are looking at antifungal drugs, we also need to consider the side effect profile. The amphotericin are associated with infusional reactions, hepatotoxicity, nephrotoxicity. I'll just focus on the broad categories here. So the triazoles are associated with GI upset, hepatotoxicity, and liver failure. Echinocandins are usually more well tolerated. So when deciding what drug to use, you need to ask what is the bug or what's the fungus associated with, what's the spectra of activity, what are the side effects of the drug, and what are the drug-drug interactions. So for patients with fungal infections in the ICU, there are a few possible scenarios you can encounter. The first up would be maybe it's a patient in the ICU, there is a new fungal infection which have developed. So the teams have to have an index of suspicion. You need to think about at-risk patients. You need to have timely evaluation and management in terms of diagnostics, antifungal therapy, or sometimes even surgery. So the second group would be a critically ill patient with a pre-existing fungal infection. These are usually the immunocompromised hosts, the HEMP-ONC or the transplant recipients, patients with complex surgical issues, and then they come into ICU for organ support. This would have bearing on the selection of your antifungal therapy and how you would anticipate complications arising in this group of patients. The third thing we have to think about is how do we prevent fungal infections in the ICU? And the fourth would be this idea of being vigilant or cognizant of fungal outbreaks. in the ICU, being a whistleblower and getting the infection control or the infection prevention team to come in and do their investigations and proceed with following corrective measures if necessary. So these are patients in the ICU. So to be fair, with these patients with fungal infections, these are the patients that you will see. So first, this is the host. Most of the time, they are the hem-onc patients or the transplant recipients. You need to think about the therapies that they have received. The second category would be the surgical patients with complex surgeries. And of course, in the ICU, with all the tubes going in and all the instrumentation, they are at risk. And don't forget our environment. Sometimes there may be construction work going on. With construction work, there'll be mold, there'll be spores in the background. And you need to think about these spores coming in to the ICU environment, and potentially our patients may acquire these funguses. So before we move on to discuss common fungal infections in ICU, that we have this concept of risk. Now, a lot of the risk is associated with the host. The host predicts the type of fungal infection. If for invasive candidiasis, you're talking about the vascular patient, those with broad spectrum antibiotics, TPN, hemodialysis, prolonged course of broad spectrum antibiotics, neutropenic patients with mucositis, those who are mechanically ventilated, or the neonates. For the mold infections, namely invasive aspergillosis or zygomycosis, they are your bone marrow transplant recipients or your hem-onc patients who are hematology patients who are severely neutropenic, and they could be heavily steroided. For invasive aspergillosis, sometimes patients with chronic lung disease may be at risk, or those with recent respiratory viral infections. And zygomycosis, we also need to think about inoculation. Sometimes it could be trauma, inoculating the mold onto the site of infection, or it could be related to surgeries. The other less commonly seen categories are things like cryptococcosis or histoplasmosis. Usually, these categories are associated with advanced HIV, and also for breakthrough infections, a breakthrough yeast infection that's common would be the trichosporum. These patients are frequently on echinocandin therapy with vascular access issues. So this is the kind of concept that we're talking about. And how can our patients acquire these fungal infections? You either inhale them, so it comes in through the nose or the sinuses, inhaled to the lungs, or it could disseminate through instrumentation. And sometimes the mucosal surfaces are also potential sources where the fungus could get in. For example, in mucositis, the Candida gets into the bloodstream, it develops a disseminated candidemic process of skin, bad skin, Candida on the skin going in. And for the Mycomycosis, it's inoculation. So for the epidemiology of fungal infections in ICU, we know that the prevalence of invasive mucormycosis is rising. And for the purpose of this talk, I'll just focus more on these two big topics or themes. First is invasive candidiasis, and the second is invasive aspergillosis. And candidiasis by far is most common. So I asked myself this question, and when thinking through the invasive candidiasis, it almost feels like a reflex action when we think about the risk factors discussed earlier: broad spectrum antibiotics, lines, chemosurgery, Candida, just give the echinocandin, case closed. But hold our horses, there are many things to consider through this common topic in the ICU. There is a spectrum of Candida infections in the ICU. Approximately 7 in 1,000 patients who are admitted to the ICU will acquire Candida bloodstream infection. And of course, there are so many surgical patients in the ICU. A lot of them have intra-abdominal candidiasis. Less commonly encountered would be things like Candida endophthalmitis, endocarditis, meningitis, pleural disease, bone or joint infections, hepatosplenic candidiasis. And just to say that Candida pneumonia is rare. Regardless, when an invasive candidiasis have developed, the mortality rates are often high, 40 to 60%, and it's higher in cases with delayed treatment. Therefore, the need to be vigilant, to suspect it early, to work the patient up early, and in some cases, we need to start empiric treatment prior to the return of culture data. So the host factors we've talked about earlier, and they are very, very important to consider. Some of the other risk factors for invasive candidiasis include like multiple colonization of Candida at various sites, broad spectrum antibiotic use, TPN, dialysis, being critically ill in the ICU. Some of the patients admitted to the ICU may be elderly, diabetic, having renal failure, multiple instrumentations, and the longer they are in ICU, the higher the risk of invasive candidiasis. So these are some factors to consider. So diagnosing invasive candidiasis in the ICU there's so many risk factors discussed. It sounds almost like every other patient in the ICU. Can we risk stratify this group of patients further? And the next question we ask is, can we diagnose Candida infections faster and more accurately? And what treatment can we institute to improve outcomes? So these are the tools that we have. There are multiple prediction tools discussed: the colonization index, Candida score, the Ostrowski-Zeisner formula, and then we want to go on to detect Candida. Now, in the field of microbiology and infectious diseases, our therapeutic and our diagnostic options have expanded in the last 10 to 20 years. Very often we think about culture data, direct detection, but cultures take time to come back. Sometimes you have indirect, You have indirect detection either via surrogate markers or PCR tests. And the surrogate markers here would be things like Candida menin and anti-menin antibodies or the beta-D-glucan. This is not well studied, not well used. We'll not focus on this for the purpose of the talk. And the up-and-coming tools are the PCR tools that we have in our kit, which may not be so widely employed yet. So first up, let's consider our Candida prediction tools and how do we apply them. So there are a few caveats here to consider. So, when they run the Candida colonization studies to use it as a tool, they often sample the patient's skin regularly and determine their degree of Candida colonization. But Candida colonization doesn't mean that all these patients will develop an active infection. 5 to 30% of patients colonized will develop an infection. It has high sensitivity but low positive predictive value. And with all these prediction tools, there's a tendency to overuse antifungal agents and therapy. And this is not without harm in terms of toxicity and cost to the healthcare system and cost to the patient. These are ultimately tools for risk evaluation, but they are not diagnostic tools. And also we have to think that consider this, a low-risk patient doesn't mean no risk. So it has to be interpreted in the appropriate clinical context, and the patient's course has to be charted before we can make final conclusions. They have to be coupled with appropriate diagnostic tests. There has to be some form of clinical acuity involved. And maybe in some form of stewardship application, when the Candida scores are low and the patients are doing well, then perhaps there's a low probability of fungal infection, and in these settings we may refrain from using empiric antifungal therapy. So what about our microbiological tools? Is the Candida diagnosis proven, probable, or possible? So most of the time we use the culture data as a gold standard. This gives us the ability to identify the species of Candida detected. It also gives us sensitivity, antifungal sensitivity data, but the yield is often low, maybe at best 50%. It takes time to obtain the diagnosis, and it doesn't fulfill our aim of having an early diagnosis with a view for early treatment. And because candidemias may be so transient in this group of patients, it may not always be picked up by the blood culture data, and sometimes there may be deep-seated infections. So let's shift gear and look at the biomarkers now. We have the beta-D-glucan that's not widely available at most centers. This is a pan-fungal kind of antigen detection assay. It doesn't just pick up Candida, it may pick up Aspergillus or Pneumocystis. It gives us the ability to diagnose Candida infections earlier. Some studies suggest that the positive results may occur 10 days prior to the diagnosis of Candida infections, but this is costly. It's useless if you collect the test and you can't get results immediately. And don't forget, the possibility of false positive results. For example, post-surgery hemodialysis patients, when the patients are packed with gauze, they receive blood products, IVIG, albumin, or antibiotics, it can result in false positive results. And in this sense, it may not be so useful in ICU patients. I'll skip through the menin and anti-menin antibody tests. It's not well studied. The next step, and I'd like to spend a little bit more time here, would be the molecular diagnostics. So there is an expansion of PCR tests and diagnosis. Recently, a lot of things are diagnosed via PCR nowadays, and there are also Candida commercially available Candida PCRs available. So the SeptiFast test and the Candida T2 panel, this detects Candida faster. The corollary is that there may be false positive results. It is costly. It doesn't identify the Candida down to the species level, and it doesn't give us sensitivity data. And in all these panels, you only select key and important Candida to include in their panel. So if you have an uncommon Candida, you may miss those infections. So like I mentioned earlier, molecular diagnostics are going to get more common. It's a rapid diagnostic. It means that it could give us early intervention. And these are the two kits that we talked about for the T2 panel. It detects Candida albicans, glabrata, Paracelopsis, tropicalis, and the Krusei. They are adjuncts to cultures, but they do not replace cultures. So this T2 panel is now approved. So what happens is you draw blood samples, you put it through a machine. This is automated. And within 3 to 5 hours, most study report getting results in about 4 hours. You can detect the 5 Candida species mentioned earlier, and it enables targeted therapy. This is in contrast to your traditional culture data, where you draw the blood cultures, multiple sets, large volumes, you incubate them. The results may come up like anywhere between 1 to 5 days later, and you need additional time for identification of species and susceptibility testing. And this panel gives us a sensitivity of 91%, specificity of 99%, and it detects up to 1 to 3 colony-forming units in your blood test for detection. Okay, so if it's negative and the negative predictive value is high, so perhaps in some of these cases, we can use this as a tool to discontinue antifungal therapy. So we talked about this earlier. The only downside, it's expensive, it's not widely available, and there's a limit to the number of tests you can perform at any one time because of the limited number of cartridges that you can put in through this machine. So we have to select our patients to run all these tests, but not perform it on every person that comes through. So this is how they design or how they think about the use of the T2 Candida panel to test this new technology. The authors identified patients to be tested on with a positive Candida blood culture already, a diagnostic blood culture. And then they went on to collect further samples to detect Candida via this PCR method and to draw companion blood cultures at the same time. So this was what they did. They enrolled their patients, and some of these patients have either antifungal therapy present already, or some of them did not have antifungal therapy, and they went on to analyze the utility of this T2 test. I just want to highlight here that for patients with and without antifungal therapy, you can get blood culture negativity and positive T2 tests, which allows us to increase our diagnostic capacity for invasive candidiasis. So it can pick up infections, bloodstream infections that are missed by the blood cultures. It also may improve care by shortening time to Candida detection. Now let's review our diagnostic strategies with all these tools that we now have in our toolkit. So think about the prediction tools first. Prediction tools often utilize this concept of colonization. For our patients admitted to ICU, they may not be colonized at first, and then later, subsequently, they will get colonized with Candidas. For some of them, they may have low-grade colonization first, and then some of the high-grade colonization cases, you see the thrush in the mouth and on the skin. And with instrumentation, broad-spectrum therapy, and invasive procedures, some of them go on to develop clinically significant Candida infection. Now, at that point in time when they may be colonized with Candida, high-grade kind of colonization, this is where the role of Candida PCR and the biomarkers may be relevant. So maybe there's some form of invasion or some form of exposure to Candida already. The biomarkers may start to be detected, and then of course there's an incubation period and before the full infection develops, and as the infection progresses, then you pick up more of these based on the biomarkers and the Candida PCR. So with this in mind, this is how these are the management strategies in our ICU, right? We think of high-risk patients as this concept of prophylaxis. I'm not saying that we should do this, but these are the strategies involved. We think about prophylaxing our patients. We think about picking up a group of patients earlier using the biomarkers or clinical scores. Sometimes these tests are not available. Then we, based on our clinical evaluation, and start them on empiric antifungal therapy. And when cultures are finally returned, we conduct targeted therapy based on culture-directed data. So depending on which strategy you use, the targeted, if you only start antifungal therapy when you have already isolated them, the Candida, then it's not surprising then that your mortality rates are going to increase. So you have high-risk patients, which you may want to consider prophylaxis, and this will include patients with GI perforations, anastomotic leaks, the solid organ transplant recipients who are high risk, which are your pancreas and small bowel transplant. And you think about your empiric therapy, right? Based on clinical diagnosis. But the downside to this is that you may be over-treating a lot of patients here. And then if you think about the preemptive therapy approach, you collect all these biomarkers, which may not be available at your center, but some centers have them. Healthcare costs will increase, and we also have to consider the interpretation of all these biomarker results. And sometimes there's the indeterminate zone, and you may need a few samples before you can confidently conclude that this is invasive candidiasis for reasons of false positive test results, as discussed earlier. When you wait for cultures to come back, whoops, too late, outcomes are likely to be poor. So now with this concept of empiric versus preemptive approach, the experts in the field now feel that the empiric approach is favored above the preemptive approach. Reason being that the cutoffs are not determined for the biomarkers, and one way to approach this would be you suspect a Candida infection, you perform all your culture data. If you have biomarkers, you can perform them. You initiate antifungal therapy first, and when the cultures return, you don't continue to prolong your antifungal therapy. You assess clinically, you use your culture data and your biomarker data to guide treatment, whether you're going to continue or de-escalate or stop. So we talked about this earlier on, just to highlight that isavuconazole is the newest triazole in the market, and it has Candida activity as well. And it's similar to posaconazole in terms of its spectrum of activity. So now when it comes to treatment, targeted treatment, you have a documented Candida infection, you change the CVC, you ruled out Candida endophthalmitis, you proceed to perform source control, and you consider it before culture results come back. We have to consider prior antifungal exposure, because with antifungal exposure, you select for resistance, it will affect your choice of antifungals. Then you need to think about what's going on in your ICU, because it will also affect your choice of antifungal therapy. So fluconazole, usually it's for Candida albicans, but for some Candida species like Candida glabrata cruzi, they are going to be fluconazole non-susceptible or resistant, and therefore echinocandin would be better in that group of patients. So you need to know what's in your ICU. And then it also depends on your hemodynamic stability of your patient, their end organ impairment, whether they have renal failure, liver impairment, before you select between an echinocandin or fluconazole therapy. And when the patients are stable after a course of echinocandin therapy, you can consider transitioning to fluconazole based on culture data and clinical status. Yeah. So based on the latest guidelines in the IDSA and the ECSMIC guidelines, echinocandins are now recommended to be first line for the treatment of invasive candidiasis due to the changing epidemiology of Candida infections. In a lot of well-established centers, Candida glabrata it's getting more and more common. It's about 30% in some ICUs, and it's fungicidal. It has shown to have better outcomes in clinical trials. They have better side effect profile and a more favorable drug-drug interaction profile. But having said this, before you select your drug, you also need to consider the site of infection, because echinocandins doesn't get into the brain, doesn't get into the eye. And of course, we always select based on culture data. So this slide here just tells us the changing epidemiology of Candida infections. It has shifted. In some places, Candida albicans is more common. If it's more common, then of course the fluconazole therapy would be better. But when there are non-albicans species, and you know that glabrata rates are high in your center, then the echinocandin may be more suitable. So in a Danish study, without use of antifungal prophylaxis in the critically ill patients, you see there's a lot of Candida albicans. As the number of days of antifungal prophylaxis increases, the proportion of Candida albicans actually decreases. And this is where fluconazole is mainly used as an antifungal prophylaxis agent. So it kind of highlights or demonstrates the concepts that we've discussed. And then for the antifungal prophylaxis, depending on whether you use fluconazole prophylaxis or caspofungin prophylaxis, the spectrum of Candida infection again shift. So there's a lot of antifungal use nowadays. It just tells us that when you use these antifungal drugs, you're going to select for resistance, and this highlighted by the study at Duke, where there's a lot of fluconazole use. Your fluconazole resistance increases, and the same for the echinocandin resistance in the Candida glabrata species. And of course, Candida auris has emerged. It's drug resistant. It can be misidentified, associated with outbreaks. So to do this, we need to be aware and vigilant for this. And when you identify it, you need to inform infection control. This is present on environmental surfaces, and it can pass from person to person. And outbreaks have been described in the ICUs, and this is mainly through environmental contamination. Candida auris was found in this Oxford Neuro ICU on the reusable equipment, the skin surface auxiliary temperature probe, and when they removed the probes, the Candida auris cases came down. Due to the limits of time, I'm just going to talk about this very quickly. We have Aspergillosis in the ICU, and there's actually a spectrum of infections associated with invasive Aspergillosis. And in the ICU, we're probably encountering this, the invasive pulmonary aspergillosis. It can affect the sinuses and the brain, and also can affect bronchial systems, the endobronchial aspergillosis. And when you do your bronchs, these are some of the places or things that you might want to consider. The patients at risk have changed with time. Traditionally, we think about the hem-onc patients, but over the last 10 to 20 years, there are use of biologics, small molecule inhibitors, the CAR T-cell therapy coming up, and more recently with the influenza outbreaks and the COVID outbreaks, we are also seeing pulmonary aspergillosis following respiratory tract infections. So there are host defenses against aspergillosis. The first line would be our lung, the ciliated lining, and then innate defenses with the epithelial cells, dendritic cells, and the alveolar macrophages. And then subsequently, they have this T cell that is involved for neutrophil recruitment and fungal clearance. And it's therefore not surprising that when your patients have airway diseases, or when you affect the T cell function either through the use of immunologics or novel cancer therapy or other conditions which may impair phagocytosis, you're going to get a higher risk of invasive aspergillosis. So traditionally, we use the ERRTC guidelines to diagnose Aspergillus, but I want to highlight that the definition may not apply to your ICU patients for invasive aspergillosis, because your non-neutropenic patients, those with steroid use, liver cirrhotic patients, COPD patients, solid organ tumor patients, or those with respiratory viral infections are also at risk. And don't forget that it may come to your patients through contaminated ventilation systems and through the contaminated water systems in your ICU. So these are the challenges. The classical findings in radiology may not be seen, and the microbiology, you may not be able to culture or detect the Aspergillus that quickly, and negative results does not always exclude this infection. These are some of the tools. For the interest of time, I'm going to skip through this. And just to highlight that for diagnosing invasive aspergillosis in the ICU, they have modified criteria now, and some experts actually include the use of compatible signs and symptoms to include it in their diagnostic criteria to identify patients who may be at risk. And so everybody is very interested about COVID these days. There is aspergillosis following influenza, but there's also aspergillosis following COVID. And this occurs in about 10 to 30% of critically ill patients with severe COVID with high mortality rates. And only 20 to 30% of these patients have a positive serum galactomannan, perhaps suggesting that Aspergillus in this group of patients is not airway invasive yet. So some postulations why this may happen: there's immune dysregulation, use of immune modulators for the treatment of severe COVID, and there might be host and environmental factors involved. So the treatment for invasive aspergillosis, the first line would be voriconazole and isavuconazole, as mentioned earlier. For drug-resistant or refractory cases and for salvage therapy, sometimes they use voriconazole and enidulafungin, but there are also resistance involved. So we need to request for sensitivities, use therapeutic drug monitoring to guide us, think about drug-drug interaction, and some of these things are available on apps. And for drug selection, it depends on the fungus isolated and the patient profile. So last but not least, there's mucormycosis. This is just a very quick slide. You have at-risk patients, and these are some of the cases that you would see: rhinocerebral mucormycosis, pulmonary mucormycosis invading the diaphragm in a stem cell transplant recipient, or surgical patients having mucormycosis in their surgical wounds. The treatment is actually scapulomycin, if possible, chop it out. And of course, beware outbreaks which can occur in your ICUs. So with this, I'll just end my talk here, just saying that it's a complicated topic, but if we can approach it systemically, we risk evaluate them, we obtain tissues for diagnosis, we think about timely diagnostics and therapeutics, and we think about prevention or things in the environment that would affect our patients with these infections. Hopefully we can achieve better outcomes. Thank you.
Thank you, Jasmine. So I think we will leave the questions to the end, and then we'll just go straight into the next talk, which is very, I think, quite timely, given the first two talks. You know, we're seeing increasing resistance. It's harder to treat the bugs. Diagnostic tests are lagging behind. You know, but thankfully for us, we have a a superstar in our midst. She's involved in all the, current worldwide things in terms of diagnostic, the new stuff, the novel stuff. So Professor Andrea Kwa is a ID pharmacist, and she does a lot of work locally and around the world to help all of us with managing infection control, infectious diseases, and for doctors who fight infection. The ID pharmacist is truly our best friend, correct? Yeah. So with that, I'll let Andrea talk to us about how we can integrate these novel things into our fight against antibacterial resistance. Thanks, Andrea.
Hi, thanks for having me here. And I would like to thank Dr. Chan for the kind introduction. So, so what I'm talking about here today is not really that novel, just logical thought process here. Okay.
Yeah, but you're really involved in what's new, so it'd be great to learn.
Thank you. Okay, let me share my slides. Okay, can you see my slides?
Yep.
Okay. Let me do the pointers. Okay, so this is me. I'm just going to explore the strategies that we should be employing in the treatment of AMR. So we know that by 2050, we are going to have higher deaths due to AMR. It's just that it's not like a pandemic, it's a sustained release type of pandemic going hands-on forward. All right, and we are actually in the midst of this area where there's high resistance rates, much higher than you see in Europe and in North America. And when that happened, AMR was going to cost a lot of money and it will cause a lot of economy issues as well. So I'm just going to run through a concept map for considering carbapenem resistance, which we think if you have a carbapenem resistance, it's almost extreme drug resistance or pan-drug resistance status, because we know that carbapenem is kind of like our last resort already. All right, so if you have a carbapenemase production, you can it can be classified into class A, B, and D. We also have non-carbapenemase production rendering carbapenem resistance. You can have the point channel closure, efflux, and many other beta-lactamases other than the carbapenemases, which is actually pretty endemic in this part of the world. All right, like for example, your GES. So we know that carbapenemase production organisms are a global scourge because they can transfer these carbapenemase plasmids from one species to another species. And this is the data that we have in Singapore. That is I can only show published data. I can't show something that we have that is in, what everybody knows in the hospital. So this is, we have rising rates of carbapenem resistance in Singapore for quite some time. I think in the last recent 3 to 4 years, it has sort of stabilized, but the percent of carbapenem resistance has increased.
Hey, sorry, Andrea, sorry,
yes.
Just stop you for a sec.
Right.
Can you change your slide view to the slideshow view as opposed to presenter view? Because it's coming out very small for the audience.
Slide post view. So this is a presenter view, is it?
This is presenter view, so need to go to presentation slideshow view.
Presentation slideshow view. Hold on, let me stop this presentation slide.
Yeah, this is better, yeah?
Oh, that one, okay, I see.
Yeah.
So this is better?
Yes, yes, this is good.
Okay.
Andrea, it's still quite small. Yeah.
Is it better?
Yeah, but it's a slideshow view, the screen button on the right side.
Yeah?
The one that you click, yeah.
Is this okay? Small.
Like how you would present on the stage lah, that same button.
Yeah, this is what I have done.
Andrea, if you go up to the top left, I think use slideshow, the middle button. Yeah, try that.
Ah, I see. Okay.
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 See? Ah, okay. Better.
Okay.
All right. Sorry. Okay, so we have 4 types of carbapenemase production in Singapore. Unlike the other part of the world, the western side, they mainly have KPCs. Okay. So for us, about 2% of CPCREs in Singapore are carbapenemase co-producers. We have 2 types of carbapenemase in producers in Singapore, and we do have a lot of oxers and NTM that can be together with a KPC. And we do have a lot of different sequence types. What you have seen in Europe and in Israel, North America, they are usually the ST258. The one that we have are all these various other 30 types, which is mainly not ST258, and our ST258 are actually very mild. Okay, so let me go to the non-fermenter side. All right, this is the resistance pattern that we have. Actually, one of the most resistant carbapenem resistant gram-negative bacilli in Singapore is still Pseudomonas and Acinetobacter baumannii. Most in SGH, our strains is actually pretty resistant, up to about 20% is resistant to tigecycline for ABAL, and for Pseudomonas, there's about 20% resistant to polymyxins as well. The MIC90 is pretty high. So because of the MIC90 that's high, usually we don't do polymyxin B alone. We will we'll go with a combi. So for ceftolozane tazobactam, which is sort of still new, and you know that in US it is being used in very high success rate for carbapenem-resistant Pseudomonas, but in Singapore, less than 30% are susceptible in those CRPAs. All right, so if you want to use ceftolozane tazobactam in Singapore, you have to make sure that it's susceptibility guided. So in the recent years, we have seen an explosion of beta-lactamase inhibitor therapy. So the red ones are the new ones that's going to come out or has already come out. Cefepime VNRX is the next promising one, which is currently in phase 3 studies. So I'm just going to show you, get you familiarized with this carbapenem ambler class thing. So these are the, can you see my pointer? Okay.
Yes.
Okay. You can see my pointer, good. So for class A, usually that's where we see your KPCs are in, all right? And usually you have your CREs in there. And for class B, you have the metallo-beta-lactamases, that's where your steno, the VIMs and the IMS, and even your ABAL, Pseudomonas, that will be in there as well. For class C, usually is the extended beta-lactamases. For class D, you will see most of your oxas, which will be can be manifested by your ABAL, Pseudomonas, and E. coli. Okay, next thing. So once you're familiar with your classes, all right, you can see that all these different beta-lactamase inhibitors, they inhibit different types of classes of those beta-lactamases. So, and you can see from one glance that no one of them actually covers all the class, all right? In fact, the one that is most comprehensive is avibactam, but it doesn't cover your beta-lactamase, your metallo-beta-lactamases. And so what can we potentially use as empiric if we know that our carbapenemases and beta-lactamases are so varied? So potentially we can use cefiderocol, prazomycin, irabacycline, muriparvadin. But the thing is, we know that cefiderocol is not registered in Singapore yet. Prazomycin has gone bankrupt. And irabacycline is the one that has been recently registered in Singapore in the midst of COVID. All right. But bear in mind that they don't cover Pseudomonas, and I would still think you should do susceptibility testing first before you start using this as empiric, or at least know what is the MIC90 of your irabacycline. It's somewhat similar like tigecycline, but it's supposedly more potent. What are the other mechanisms mediating carbapenem resistance? We have efflux, we have the decreased outer membrane permeability. That's what we call loss of porine loss. So in SGH, our isolates are mainly, they have 40% of them have decreased porine expression. So that means all your avibactam, your relibactams, or the beta-lactamase inhibitor has problem coming in. All right, so which is why with this, you will start seeing an increasing susceptibilities to Septas AV as well. Okay. So this is our data from our lab, from SGH as well. So if you look at this trend, when there's increased porine loss described by the blue bars, you can see that the MICs to Septas AV actually increases. So I think the break point is 8. So but between 2 to 4 is almost intermediate. All right. And if you are using Septas AV to treat pneumonia, for example, it's going to be a little bit more difficult, okay? Okay, so take home message part 1, we need to have antibiogram that correlates with molecular mechanisms other than just, and not just percent susceptibilities, in order to guide us to know how to which new antibiotics that we can use. Because without these molecular mechanisms of resistance, like your which type of carbapenemase production, there's no way for us to be able to start an empiric precisely. So what do we have now for rapid molecular diagnostics, especially in Singapore? We have our CARBA-R, which is your gene expert. We have the BioFire. We also have Univarial with cartridges for all these different syndromic infectious disease. So what is being registered here for Univarial is actually blood and hospitalized pneumonia, but they do, I know the private hospitals do use the rest of the kits as well. Okay, so for other rapid diagnostics that has been used in other part of the world, in US and in Europe, so you have the MRC, real-time PCR for your MRSA, MSSA differentiation. You have the other types of multiplex PCR, and multi-TOF, we have it in Singapore as well, but the problem is it's not so rapid. You need positive isolation first before you can use multi-TOF. We have this PNA fish that is being used in US for the past 10 years already. Okay, so rapid diagnostic tests. It is good if you have a country that is had high resistance rates, because you want to enhance the rational use of antibiotics empirically. You want to be able to tailor the individual patient treatment and management, also to facilitate surveillance, and to also allow the use of effective narrow spectrum antibiotics possible. Okay, so we have BioFire in Singapore. I think it's already registered with HSA. These are the different panels. The one that we have in Singapore right now should be the pneumonia ones. So it's pretty easy to manipulate. 2 minutes of hands-on time and no precise measuring and pipetting required. Turnaround of in about an hour. Okay, so we have the Respiratory Panel 2 Plus that's being launched in Asia. But I don't think many hospitals has this panel yet. So since this is more of the upper respiratory tract kind of infection, so there is also the Pneumonia Panel Plus, which is an improved version from the first version. And they have incorporated actually COVID-19 testing in this. So I'm going in to talk about Univarial, which is I think what we have seen in the private hospital already. So how is it different from with the BioFire? So BioFire has Streptococcus, this yellow Alagardisi and Streptococcus pyogenes, whereas Univarial don't have, but Univarial have this other two here. And BioFire has this MREJ gene, but for the new Univarial, they have the rest of the genes here, which is actually broader. Okay, so these are the red ones, the red square box ones are those that are found in Univarial respiratory tract system, but not found in BioFire. So these resistance genes can actually sort of guide you to institute the right empiric antibiotic therapy before your cultures come back. Okay. So you have the Univarial blood cultures as well. So you have the fungi in there, all kinds of Candidas, including Aspergillus as well. And we have the resistance genes in there as well. So that will guide you for your empiric therapy. You have the Iei Panel, which is, I think, by far from my own personal experience, Iei is something that I really like because of all this panel here. For implant and tissue infections, my knowledge is you can even crush the bone and you can tell what are the likelihood of a bacteria that's in there and the resistance gene. So all this Univarial and BioFire, you don't really need for positive culture to be positive first before you can use that. And okay, if you're talking about Univarial blood cultures, you need for the bacterial bottle to turn positive first before you can use it in a Univarial machine. Okay, you have the UTI infection cartridge as well, same thing. Okay, so the uptake and adoption of validated RDTs is slower than expected because primarily RDTs has not been recommended to replace traditional gold standard, and yet it is pretty expensive. So we don't know what is the cost effectiveness of these new RDTs, and we are also mindful that improving technology is always associated with higher direct cost. But yet we know that if we can use RDTs, it should help us improve our overall diagnostic yield in a timely manner so that we can use effective antibiotics. So when should we start using it, especially in public healthcare? I mean, for private hospital, it shouldn't be any problem adopting it, but for public healthcare, it is a problem. Okay, so so my thought is we should use it as an adjunct to guide adequate antibiotic therapy in high-risk cohort, that means in cohorts with colonizations of carbapenem-resistant infection or MRSA on VIEs. All right, so, and because we know that in patients who are colonized with carbapenem-resistant Enterobacteriaceae, actually only 10 to 20% of these people will acquire infections. So that means if we know that they are colonized, are we going to start polymyxin right up? and eventually we may have to stop them after 4 days when we know that they are not having the infection. And we do know that polymyxins has a high nephrotoxicity rate. Okay. So take home message part 2, using molecular methods to guide rapid susceptibility testings and empiric antibiotic and or combination selection is important in this AMR era. So the next thing I'm going to talk about is something that we have been doing in our lab for the past 10 years already. So we are looking at antibiotic combination therapy for resistant gram necks. So combination antibiotic therapy has been proposed as best practice thus far. And the ideal antibiotic combination should be strain-specific, selected based on sites of infection and PK profiles of each antibiotics. That means you have to make sure that these two antibiotics meet at the site of infection first before you select them. So the doses have to be based on optimization based on PK/PD target attainment rate. We may be able to leverage results from in vitro animal models, and it should be available to clinicians in a timely manner. So there are a lot of variability in effective combinations all over the world. And I can say that no one combination hits all, it's all very strain specific. And if you look at this result that we have in US, in Europe, they have found that if you use dual carbapenem, you can actually target KPC producing CREs. But that's not the case with us. So you can see that from here, even if you have KPC here, we still need a carbapenem plus polymyxins. That's possible here. And because with MC added into the KPC, the phenotypic MICs of these antibiotics went in a different direction. Okay, and then if you have a KPC plus a porin loss or efflux pumps, so all these phenotypic things are also changing. And it's important that you know your MICs and your different resistance mechanisms to know what kind of empiric combinations that's possible. Okay. So is this prospective antibiotic combination testing service is something that we do in SGH, and we do provide this service to the public, private sectors as well by request, because they may have started empiric combinations, and usually these empiric combinations involves every antibiotic in each class. So with this combination testing service, they are managed to peel off the required number of antibiotics and zoom into the target combinations that they need. So if you receive your isolate today, we will be able to let you know which antibiotic in combinations are at least bacteriostatic. Then you give us another 18 hours more, we will be able to tell you effective combinations that is bactericidal. And based on PK/PD and which antibiotics will meet at the site of infection, we'll let you know which combinations to use, and we'll also guide you on the dose that you use so that you can achieve the right concentration at the site of infection. So what I've covered till now is antibiogram that correlates molecular mechanisms of resistance. It is important to guide us which empiric antibiotics can we potentially use in our hospital, our setting, because right now the new antibiotics comes with various types of beta-lactamase inhibitor that targets different types of beta-lactamases or carbapenemases. So we need to use molecular methods to guide rapid susceptibility testings to improve our empiric antibiotic prescription. And we know that how to know which antibiotics in combinations or monotherapy is useful for your particular bacteria that is isolated or growth. We are actually advocating strain-specific antimicrobial in combinations testing to guide choice. It's just like a susceptibility testing, but we can't use the usual susceptibility testing because it's no longer informative. Everything is resistant. It doesn't tell you anything. And the next thing I want to touch on is we need to optimize antibiotics PK/PD to achieve the maximum killing via TDM, especially in intermediate susceptibility category. So in our hospital, we have a new category that is called dose according to susceptibility according to dose. It has replaced intermediate category. So previously it had SIR, so it has replaced I, and now we call it SDD. And how do you know whether your dose falls within the SDD category or not? You have to use TDM. Okay. All right, I've presented this before in the ICU conference, I think some years ago, and we did have this national beta-lactam TDM that I've done together with, I think, Jonathan as well in there, and Ling Li Min, Dr. Ling Li Min. So we have several levels taken within 48 hours of the sepsis and after the sepsis died down. So we found that actually the levels for meropenem, we did meropenem and piptazole only at that time, and it's very varied, even though we use similar doses for similar patients types. But you can tell that the range, the minimum and the median value and the maximum values are so varied because of the different pharmacokinetic factors, variability in each patient. And not forgetting that part to compound the problem, and we are treating different types of infections, and you know that the drug distribution to the different sites are also different. Okay, so just by comparing your meropenem 1 gram, 2 gram, Q8 hourly, all right, so you can see that the variation in the levels achieved is huge, even between your 2 gram Q8 as well. So we have in our lab developed this 11 antimicrobial drug assays for plasma. We have already started our implementation science study to make sure that it's feasible to carry out this TDM for this 11-12 drugs assay. We have already recruited I think about 50 over patients from our ICUs. I think our SGH ICU consultant can attest that. And with this use of TDM currently, we have new realization of how we should dose actually some CRRTs, SLAG, and intermittent high flux dialysis, not really following the guidelines. Okay, so now we are also customizing drug assays for ELF and IAI. So let's say if you manage to send me sputum, if you manage to send me IAI fluids, I would be able to know the levels in time to come. I've talked about optimization of PK/PD to achieve a maximum killing, strain-specific antimicrobials in combination, and the need to use molecular methods to guide rapid susceptibility testing and empiric antibiotic selections. Now I'm going on to novel preventions and therapeutics. So we have new antimicrobial compound testings requests that we do in the lab by various faculty people, but so far not very successful for all the new antimicrobial compounds. So it's very difficult to actually develop new antimicrobial compounds. All right, and the next thing we are looking at is using relevant microbiome reconstitution to reinstate necessary diversity and inoculum load for elimination of multi-drug resistant pathogens. We are also doing some made cells, and I'm sure in private sector you have used your fair share of target immunoglobulins or pentaglobulins for one as an adjunct to treat antimicrobial resistance. And the next thing I want to highlight is what we are hoping to do is with Dr. Jasmine and potentially with Dr. Sean Basu, we hope to go into this area, bacteriophages utility in AMR. Okay, this is my lab people, my team. Without them, I wouldn't be able to do all this stuff. So I would like to acknowledge them here. Okay, and that's it. Thank you.
Wow, thank you, Andrea. In my rush and excitement to listen to your talk and introduce your talk, I forgot to tell everybody that Professor Andrea is a ID pharmacist. She is the leading ID pharmacist researcher in Singapore and around the world, and I think her talk would be testament to that. And yes, we are very privileged to be able to do a lot of things because of you. Thank you very much, Andrea. You know, KPC, CTXM for the EC307 with the OXA 361, you know, hey, you really, yeah, I was lost already, okay? So, but I have heard about how your lab is able to tailor all these treatments so specifically for the multi-drug resistant things, and it is incredible. So I will invite all questions now, but I mean, since we have you on the floor, first question is, to Andrea. I mean, how readily available is all this today? You mentioned that, you know, I know that it's only available in your lab. And it's almost as if clinicians have to know a special password, special door, talk to the right people to get these samples into you. So in terms of how we get these into mainstream therapeutics and diagnostics, you know, how far away are we and how do we go about doing that?
For the TDM part, actually we are working with Shipmazu to come up with a commercial assays based on our research methods. But at the end of the day, because we do 11 drugs using LCMS, the commercial assays won't be a step 1, 2, 3 still. So the uptake by normal hospital biochem lab may have some issues over there because they usually don't like to adopt research methodologies. Yeah. So having said that, what I have in plan is to actually turn part of my research lab setting into a GLP setting with some ISO accreditation. So then we are able to file for work plan to first start the service in SGH. And once we are able to start the service in SGH, then we should be able to get the entertain request as clinical service. But I mean, if you really have patients that you need a TDM service for, do contact me. I can still help.
Yes, I know. So that seems to be the only way, right? Through special friendship links. So I mean, with that in mind as well, I mean, we had a question earlier on from the floor, and this was directed to Dr. Jasmine. I'll just pull that question up. And it was about the turnaround time for fungal culture sensitive results. Do you practice escalation and de-escalation of antifungal based on sensitivity results? And the most interesting part of this question was when does the infectious disease team come into management? And I think this is very relevant. And I would say that the team here would involve the ID pharmacists as well. So for all of us, I mean, for all of you as well, what are your comments? You know, first of all, just the turnaround time for the culture and you know, how do we escalate and de-escalate? And then the most interesting part.
First question first, in terms of turnaround time for antifungal testing, the truth is it depends on the fungus that we're isolating, because every fungus behaves differently. They take time to grow. So typically for fungal culture result, if there is a positive culture in a patient without antifungal therapy, that may take between 72 to 96 hours, sometimes a little bit longer. Now, if they are already on antifungal therapy and then you take the culture result to get an answer, then the turnaround time is going to be longer. I think the turnaround time is not dependent on the lab because our lab is open and processing specimens all the time, but really depends on pre-treatment, collection of specimen, how good your specimen is, and the type of fungus that we're trying to grow. So we know that for all fungal culture data, the yield of cultures, even though we have collected it properly, it may still be at best 50%. So that's the first question. Now, the second question, I think I'll answer the subsequent questions in a different order. So antifungal therapy at SGH is tightly controlled. So if you're going to give an echinocandin or the higher end triazoles, usually there is an ID team member on board. So we work together in tandem with the primary physician to decide on the best regimen based on all the principles I talked about earlier. Now, in terms of escalation or de-escalation of antifungal therapy, usually these patients that we see, Candida, it's a little bit simpler because it's usually the story is usually more clear cut. You go on to use an echinocandin first, usually to stabilize a patient to get good outcomes. Then when the sensitivity results are out, then you de-escalate as appropriate, depending on the patient profile. But for mold infections, now we know that the mortality rates are high. We don't have much time to wait. We want better outcomes. So usually we hit hard first, and if we're suspecting a bad Aspergillus or bad mucor, if it's Aspergillus, sometimes it's a voriconazole or isavuconazole. If it's mucor, we may go up to amphotericin first and then peel back later. Then adjust based again on sensitivity results coupled with therapeutic drug monitoring to get best levels or best outcomes. Similar concepts to the drug-resistant infections.
So, I mean, in interest of time, I mean, I think one of the key questions is in this day and age, dealing with such a complex problem, it is really evident that we need a team, you know, to tackle this, the solution to the bugs, because if we don't kill the bugs, the patient is going to get killed in the end, you know, most of the time, isn't it? So, you know, it's a complex problem. We have all these new kits you know, that Andrea has talked about, you know, even understanding the timeline of bacterial infection in COVID patients. Gatinoni spoke a bit about that yesterday. Tao Hong, you know, showed us what happens in our local population. So I think the key here is even this attendee's question, how do we and when do we get this whole multidisciplinary team to come together is, I think, something that we need to move forward both in private as well as the public hospitals. I mean, can all of you share some of your experience in terms of how, I mean even just, you know, utilizing the Andrea's lab is a perfect example of how these collaborations must happen better and faster for the benefit of our patients. Comments, Tao Hong, I mean, in Diagnosing, and how do you see the EMI team and now the death of the EMI team as a problem?
Right, so actually the EMI team, the ICU ID multidisciplinary team was started as a value-added service for the patients in ICU. But with the onslaught of COVID, our manpower was, we had to redistribute our manpower. And so there was, we had to temporarily suspend some of these services. Having said that, there's always a fallback to refer this patient to through the traditional ID blue letter route. So you'll still get a ID advice during that period of, you know, the bad times during the last few months. Now moving forward, there is always a plan to, you know, restart this service in Diagnosing. And we are going to think about different models, how this can happen. But there's always, as I said, there's always this fallback route to doing the traditional referrals. And in terms of asking for additional service from, for example, Andrea's lab, we do request, I'm not saying we do request for Andrea's lab to run combination testing for selected patients. So usually ID will be the gatekeepers so that, you know, we don't send them too many samples, and only for patients that really need the additional service from her, we will recommend that. So we'll link up when necessary to Andrea's lab.
Yeah, I think especially as well in the private setting as well, where the connections are a bit more ad hoc. I think it's a lesson for us that we will need to rely on our ID colleagues to really, you know, look through, because all the multi-resistant properties are really quite varied. And I also learned today that understanding the molecular mechanisms. Andrea, are you suggesting that the antibiograms should really show up the separate molecular mechanisms, you know, because right now, apart from telling whether something is ESBL positive, we don't really have any other information. So that seems to be the key thing to move forward in antibiotic selection, isn't it?
Yes, if you can. Yes and no. Actually, best if you can. Not really, because our ST types and our mechanism of resistance is so varied. So you're going to have a proportion of each type as well. So the next thing actually is to complement by rapid diagnostic kit for molecular testings and ID of bacteria before the real culture comes out. Of course, that is not cheap. So you need to select your targeted group that has high yield, I mean, especially for us in public healthcare.
So a reasonable strategy to move forward in the last minute is you see a patient who's very sick. If you have available resources to do RDTs, do that at the same time as you send off your blood cultures or your whatever cultures from every source. Send off your biomarkers as well. And then once you get all these results start coming in and you see all these funny numbers, quickly call your ID physician friend, call Andrea on speed dial, and then decide what best antibiotic to use. Is that kind of sums it up, yeah?
You may say so.
Okay. And I think with that, you know, one thing that Andrea mentioned was also developing new antimicrobial compounds, and all these test kits are going to be difficult and expensive. I'll take this opportunity to thank our corporate and partners for helping to make this conference possible, and this and Pfizer being the sort of sponsor for this part of the session as well. So thank all our speakers, thank all our partners, and thank you, all of the audience, for making this a meaningful session for all of us. See you all soon live. Thank you very much.
Thank you.
Thank you.
Thank you, everybody. There's so much more questions, actually. You all can still hear me, right?
Yeah, can.
Yeah, there are a lot of things I would like to ask, actually, but well, you know, superbly interesting. So like in private hospital, I don't know what test kits they do have. You just comes up with a test, you send it off, and you know, the vastness of the mechanisms is really interesting. It's really hard to interpret sometimes and choose the right you know, bug killer. So really looking forward to you know, all of your expertise. Yeah.
I think it's important when you have these rapid diagnostic tests to also have a strong stewardship program to guide the interpretation as well as the escalation, de-escalation of antibiotics.
Yeah, which is why in public hospital, I see that is very, very possible once you have the culture and the system in place. But in private, right, then it really is dependent on whichever primary physician engaging a sensible ID physician, and then, you know, for it to be really driven by results and outcomes rather than you know, yeah, what appears to look good, or you know, readily available, or makes someone more money, you know. Yeah, so that is the challenge, I think. Yeah. Thank you all very much. Thank you for spending your Sunday with us.
Thank you.
Thanks.
Bye.
Thank you.